Being in the theme of this great conference and my colleagues that came before me this morning, I will be mindful of the fact that I stand between you and lunch. Okay, so I'm on a 15-minute countdown, so I guess I'll get started. So I'm going to present one role that wasn't on the slide this morning, and that's nurse as scientist. And specifically, my area is translational work, so I do bench stuff. I'm interested in DNA and white cells, but not for the purpose of playing with them, but really for the purpose of trying to improve patient care. Let's see. So I'm going to talk about immunosuppression. Are we ready to individualize regimens for programs? But actually, the focus is going to be on patients. How do we improve outcomes of patients, and what do we do as nurses to help patients do that from a self-care perspective? Harriet went over this, my esteemed colleague, and this is my sort of latch on from her talk to my talk, and she spoke a lot about the history, and I'm really focusing on how do I empower my patients to understand what we did to them by giving them a heart transplant. You know, we all grow up, we get to be adults, we know a lot about ourselves, and because we know so much about ourselves, we often don't want to hear what anybody else has to say. So a lot of the issue of trying to make sure that patients, we're in sync with what patients need, what we need patients to do to make their outcomes well, we have to have this sort of marriage between what patients think they know and what we need to teach them new about themselves. So what starts my question and my quest on research is a very old picture, and it's a picture of our Cedars Sinai Heart Transplant program when we started in the early 90s. And what was important, the observation the aha I had was every year we have a Christmas party, and this is an old picture, and our patients love to take the group photo, and we were a very small program at the time, a beginning program, and the thing that kept shocking me was that each year when we would repeat that party, which is a year later, some patients were not present. They were dead. And often those dead patients were African American. And I couldn't quite understand it because as a clinician, we were treating everybody the same. We were giving everybody the same transplant regimen. In the world of transplantation, there is no standardization of what patients get. There are expected drugs, best practice drugs, we give it to them, but the tweaking of the drugs are allowed based on the program you happen to be signed up in. And so I was very curious about the fact that why was it that this group of patients seemed to die? And so just a little by way of stats, as of September of this year, there were something like a little bit under 120,000 people nationwide waiting for solid organ transplant. And there were about 3,500 patients waiting for heart transplants, with about 382 in California. What's interesting is that there is about 4,000 heart transplants done nationwide. There's a need for about 4,000. There's about 2,500 that are done. So we know that there's a big group of patients that will not have available donors. So if you are lucky enough to get a donor, we really want to get the best outcome for all patients. So if you look at the UNOS database, which is the United Network Organ Sharing Database, where every single person in the US is actually logged as an active transplant, what we see is that there's disparities. They're very, very clear between Caucasians and African Americans. So why is it that I chose these two populations? Because I was interested in knowing why the African American population seemed to be dying faster. That was my gestalt. I didn't know the stats generally at the time when I started this. And that the Caucasian population of patients were typically the larger. So I was comparing one against the other, knowing that we were treating everybody the same. And you can see that their survival is not. 1, 3, and 5 African Americans are not doing so well. So I'm not going to make you crazy with science, but I got to do just a little bit, just a little bit. So in this picture, the purpose of this picture is to just sort of frame the talk, which is, and it'll be fast because I know lunch is waiting, is that that heart transplant, that heart that we put in a person is foreign tissue that we're transplanting into a competent immune system, okay? And that the drug regimens historically are chosen by organ, not by person, okay? And these drugs are the typical ones that we use, and that's not the focus of this talk. But this picture, let's see if this is, I don't know if this is going to, which one of these things will this help me use a pointer? Oh yes, isn't this fabulous? And I'm not shaking. That's good. Okay, so what I want you to pay attention here is that this is a suture line, and this, D, is donor. So this is the donor vessel, and this is the recipient vessel. And so we actually are transplanting also, besides that organ, T cells from the donor into the recipient. And so on one side you can see it's the donor, on the other side you can see the recipient. What we see here is the donor T cell, and this is a MHC, or a major histocompatibility unit, but you don't need to know that. MHC is good enough. And that little thing right there is a piece of self. So it's the way actually that T cells become smart. They actually come out of the long bone, they go to the thymus in your neck, and the younger you are, the more you make, and the more good competent ones that you make. But the thing that's important is they have an education in the neck, and if they're confused at all, they're killed. So 95% of those T cells are killed in the neck. So the 5% that they're circulating are very competent, and they understand that that's self. So here is a recipient T cell. It's going to bind to the donor. It's going to, and when it does that, it's going to secrete, oops, I'm not doing so well with the pointing. It's going to secrete these particular cytokines. There we go. And these are the ones I'm interested in. They're inflammatory cytokines. They're IL-6 and TNF-alpha, and I think we'll get back to those. And then there's one little guy that's always out here, and that's a B cell, and it actually has an antibody on its cell membrane. So it's actually ready to really start an attack for the second time that it sees the antigen. Let's see if we can make this go. Will I be lucky enough to make this? I won't. So what this slide was, but I'm not sure how to make it go, actually. Let me see if this will do it. This might do it. No, it's not going to do it. What that slide was is that every patient has to have biopsies of that tissue. So that, and what we're looking for is rejection. We have a bunch of medicines that we give them. We want to see if the medicines are working. We want to see if we've kept rejection at bay, because that's often the rate-limiting factor for that transplanted organ. So what happens is, in my story, is I end up actually in a HLA lab, and I'm looking now at, and that's what these data are, I'm looking at lymphocytes that were left over from the evaluation period to see if it at all could tell us or predict death in patients before we even transplanted them. And so what I actually find in this data is that this interleukin-6, which is an inflammatory cytokine, and specifically this IL-6GG is very prominent and in this African American group. And IL-6GG is very high, but IL-6GC is not in this group. Okay, so that was an interesting find. Additionally, if I can press this button without causing problems, additionally, TNF-alpha GG in this African American group was also high. So the combination of both of those seemed to be very interesting. And in helping me look at survival. And so what I see here is that in comparing African Americans and Caucasian heart transplant patients on these two SNPs or polymorphisms. And polymorphisms are just a variation on something that's normal. I saw a cute cartoon that was sort of emphasizing that, and the way they used it was they basically used a car, so we can use a Ford. So if you've got a Corvette, and that's probably not a Ford, because you can see I'm like not a car person. I don't know if a Corvette or a Ford are the same, I don't know. It's really about the ignition, I need to go. So whatever works, I'm in it. But anyway, if you had a car, okay, and you changed the color of the car, nothing changed on the car but the color. So that's what the polymorphism is. It's a normal variation. But the variation actually causes a different protein to be made, and that different protein has a different outcome. So that's sort of the general concept in 15 minutes so that you can get to lunch. But all I want you to notice is that what I found was that in African Americans that had a combination of this, their survival was terrible. Terrible. Now the numbers are teeny, and this was a study done a while back, but it was significant. So that suggested to me that there's obviously genetic reasons why death might happen in this population. Let's see. The other thing that was pretty impressive was that, as I said, we do these biopsies to determine if there's rejection. And a very low level of rejection, but a level of rejection that we actually act on. So there's like a 1A to 3B. So 1A, and there was a 2, but that's gone now. So there's 1A, 1B, and then there's 3A and 3B, all of which the numbers are worse the higher the number. But on 1A, 1B, we actually will augment the immunosuppression and do something a little different. But I think what's important here is the timing. Now, I don't know that I have, let me see if I have yeah, let's go to this one. This one is pretty amazing. And what this means is, from the time that the organ was put in to the first biopsy that either showed 1A, 1B, 3A, or 3B, this is the time. Now, forget the statistics. Forget the fact that the standard deviations are insane. Now, we already know the numbers are small, so none of the standard deviations are important. Just the actual time. If you're African American, to get a 1A, it's going to be 58 days after your transplant was put in. If you're Caucasian, it's 187 days. If it's a 1B, which would be something we'd act on, it would be 52 days versus 95 days. If it's a 3A, which is really, really bad, it's 130 days versus 1,200 days. If it's a 3B, which is horrendous, it's 25 days versus 500 days. Take home on this, this is a very, very immunoreactive group. And something's happening with the immunosuppression that is different in terms of what's happening for this population. Okay, so I really didn't mean to hurt you. I just want to say that there are 3 signals. 1, 2, 3. And those 3 signals really are about stopping this from happening. And that's why patients sometimes, well, we did a study while patients were in the hospital, they actually take about 40 dosages of medicines a day. Now, these are not nurses who are licensed by the state of California. These are patients who checked into the hospital to get a transplant. So if you think about the potential for error on the patient side, it's high, particularly how fast we get patients in and out of the hospital. These are immunosuppressive regimens that we use, none of which are really important for this talk. But I think what's interesting is here is a study from 2010, and this is a study of 20,000 patients. And essentially in this study, what's found is that African American recipients still have worse survival. There is still discussion as recent as last week when I was speaking to one of my colleagues about some current data that I was looking at. And he said to me, but Bernie, do you have any data on if the donor was white and the recipient was black. We should try to put that to bed if we could. Why would that be? Because the color of our skin is a phenotype. What is important here is a genotype. So that would actually be our genes. So if I report myself as white and you report yourself as black, and I give you my organ, that would mean about nothing. But it does impact the notion that we are human, and even when we're not thinking about it, this race thing is in there. So we know from this very large study, they put it to bed. They looked at, it's a UNOS database, there's no difference, so we can stop talking about that. What we know here is that this paper is from 2011. It's saying the same thing, that despite the various eras, and what that basically means is that depending on the current medications that we have to use, patients might have died because they didn't have the same medicines. But even if you look at survival by era, everybody's getting better, but the disparity is remaining. This is bunches of medicines that patients take. And I said I would talk about a case study, but I'm going to bottom line the case study. This essentially is a 48-year-old African-American female who has postpartum cardiomyopathy, which means that she develops cardiomyopathy after her last child. She doesn't get well. She has a number of issues. She's got chronic kidney disease. She's had DVTs, UTIs, and some vaginal bleeding. She is transplanted, and we have a relationship with, we're spoken hubs, so some places send their patients to us and then we send the patients back. So we transplant her, we send her back to her home hospital, and they're managing her there. But she's a lady who has a very strong locus of control. I think you could probably put a number of adjectives on her if you wanted to. And so she comes in with a list of things that she wants done, and she's going to get them done, and she's not going to stop until she gets all of her answers. And when you have to see 50 patients in 2 minutes, she's not like you're warm and fuzzy you want to have to deal with. You're probably rolling your eyes around the communication issues. And you're thinking, do I really have to go in there, and can I get out of this room, and can I throw somebody else in there to deal with her instead of me? But what happens with this lady is that the doctor decided to shut her up. And he said, you know what, I'm going to listen to you. You have these symptoms, these symptoms, these symptoms. They're all, and you think it's your medicine? Okay, we're going to change them all. So they change her from the current medicines, which we know are effective for African Americans, even though they're dying more than their counterparts, and puts her on the older medicines. So she reports back to us. She gets readmitted back to us because she comes into the hospital at her home hospital. They send her home. She's readmitted within a week. She transfers to us just about in cardiogenic shock. We biopsy her. We take her to the cath lab. We find she's 1B, but she's hemodynamically compromised. So instinctively we know that if the blood pressure's in the toilet, she's sicker than, it may be biopsy error because it's a blind drop, and that was what the video was showing. It's a blind drop into the heart to take a snap. Maybe the bad stuff was over here, but the snap was over here. So we treat her aggressively. She doesn't do well. We end up taking her to the OR to put in a biventricular assist devices because her ventricles are shot. And at that point, you have to take a big core, literally like an apple core, out of the ventricles in order to get the hoses in. We took that plug of myocardium, sent it to pathology. She was a 3B. So clinically, she was definitely presenting like a 3B, but the biopsy was a 1B. So we treated her appropriately. Long and the shortest story is the VAD gets taken out, and VAD gets taken out. She and I are sitting on the side of the bed, and I say to her, I'm going to put you on fluconazole because I'm intentionally going to cause a drug-drug interaction for you. And henceforth, no matter where you go, you are never to let anybody change your medicines again. She didn't lose her transplant. We actually were able to save her transplant. She didn't require retransplant. And she was recently, as a follow-up, she was recently readmitted last week to the hospital, and I went to see her. And the same thing she was accused of, which I didn't say earlier, was, are you taking your medicines? Because her level was always in the toilet because she happens to be a person who's carrying genes that are metabolizing those drugs very quickly. So by creating an intentional drug-drug interaction, we're able to keep her levels up so we can prevent rejection. And she was accused on this admission again, what's the problem? Are you taking your medicine? And those kinds of questions to adults who fully are doing the right thing, but they're being accused of something else, interferes with the relationship between the patient and the caregiver, which bottom line only shortchanges the patient. This is a video that's also not going to play, for which I apologize, because one of the interventions that we do is something called teach back. We teach the patient, and then we switch our roles. We come in, we sit in the chair, and we say, I'm the patient, you're the doctor, tell me what I need to know because I'm on my way home. And then I role play like I'm the patient. Well, why am I on this? And the patient has to tell me. So the patient actually is teaching back what it is they know. Even with the teach back, that's good for getting them out of the hospital, but that's just the beginning because it's really about the long term. So when I say what is it that we do in terms of our nursing role, I say we need highly educated nurses because the future going forward is just going to get very complicated, as Harriet said. The communication patterns that we need to develop with our patients that we have to figure out how to do no matter what their culture or ethnicity is, it's incumbent upon us to do that, lies with us. And the more educated we are, the more scientific we look at things, the more we drag the bench work to the bedside for the benefit of these populations which are desperately needing it, the better everybody is going to be. See? We're done.
Awesome.